immunohematology program, Oman chapter. Today we will have two speakers. One is Dr. Shadia. I think everyone is now know Shadia because she presented earlier the first webinar. She is one of the hematologists who was at our department. Currently, she's at Royal Hospital. She's a consultant hematopathologist. She will be talking about pediatric blood management. And then we'll have Halima Al-Belushi. She's also from Royal. And she will be talking about autoimmune hemolytic anemia in COVID-19 patients. So we'll start with Shadia. So the floor is yours.
Okay. Thank you very much, Dr. Zainab, for the nice introduction. So should I start now? Yes?
Yes, please.
Okay. So today I'll be, as you can see, so first of all, hello everybody, and thank you for the organizers of Asian Association of Transfusion Medicine Oman chapter to invite me to speak in this very interesting meeting. So as you can see from the title, it's pediatric blood management, very interesting topic. Oops. So I have no conflict of interest. So in the 20 minutes which I have been given for this presentation, I will, focus on the two main points in my presentation. This is first one is the significance of specific pediatric patient blood management, including how children are different from adults when it comes to transfusion. And then after that, I'll talk more about the evidence-based triggers for red cell transfusion and platelet transfusions in pediatric and neonates. So neonatal transfusion is very different from adults in that they have different blood volume, they have different hematological values, they have an immature immune system and different physiological responses to hypovolemia and hypoxia. Full-term neonate mean cord hemoglobin is 16.9 gram per deciliter, and the preterm neonate mean hemoglobin is 16, which is much higher from adults. The blood volume also differs from the adults. So the blood volume, it depends on the weight of the neonates, where full-term infant have 85 ml per kg, and preterm infant will have 100 ml per kg of blood volume. So why is there a need for neonatal red cell transfusion? One of the main problems is that they lose blood due to repeated phlebotomy, which is the iatrogenic anemia. So typically 0.5 ml of blood sample from a 500 gram infant is equivalent to a 70 ml sample from a 70 kg adult. We never take 70 ml from an adult for sampling. We only take 3 to 4 ml of blood. So you can see we take much more larger proportion from a small infant. So, and they also do not tolerate hypovolemia as well. Also later on after birth at 4 to 8 weeks, they have physiological decrease in hemoglobin due to decreased EPO production, decreased red cell survival, as well as increase in blood volume due to rapid growth. The EPO response is also, it's a bit suboptimal. So in fetus, oxygen sensor is less sensitive and it is located in the liver. This is also true in the preterm infant. They have decreased EPO production in response to hypoxia. The premature neonates, they make very small amount of EPO in response to anemia. Recombinant EPO has been shown to improve anemia and decrease the donor exposure in preterm infants. However, the effect is pretty modest and it is thought to have neuroprotective role, but also has some risk. So it has a risk of retinopathy of prematurity related to pathological neovascularization. So that was a little bit about the specifics of the pediatric patient blood management. Now I'm gonna shift gears to the patient blood management. So what is patient blood management? It's defined as encompassing all aspects of patient evaluation and clinical management surrounding the transfusion making process. In the other words, it's an evidence-based multidisciplinary approach to caring for patients who might need a blood transfusion. And when transfusion needed, patients are given only what they need, and that the lab testing is carefully selected and transfusion is prepared and given in a safe manner to these patients. So I'll spend most of my presentation now talking about the evidence-based triggers for transfusion in children. And I'm going to start by talking about evidence-based red cell transfusion triggers. And what we are talking in these studies, which I'm going to show you later on in the presentation, is when do you give red cell transfusion in hemodynamically stable patient? Do you give the product where their hemoglobin or hematocrit is higher or lower? Which of these situations is the better time to give the transfusion? So in adults, there have been many randomized controlled trials comparing the liberal versus the restrictive transfusion approaches. And most of these studies uniformly favor the restrictive arm approach. In pediatric, it is the similar question. However, the population is very different. Therefore, randomized controlled trials are required in children specifically to see if this is the right approach to transfuse pediatric patients or not. So now I'll go through the key studies in children looking into the red cell transfusion triggers. The very first study addressing this question was the TRIP ICU study, transfusion trigger strategies for patients in pediatric intensive care unit. It was published in New England Journal of Medicine in 2007. So there were 637 pediatric ICU patients who were randomly, assigned to either restrictive versus liberal transfusion. These ICU patients were hemodynamically stable, so the transfusion the decision was dependent on the laboratory test. And as I said, so they were randomized to either restrictive arm versus liberal. The endpoint was multi-organ dysfunction score, and the question when a patient is given a red cell transfusion where their hemoglobin is 7, or when a patient is given a red cell transfusion when their hemoglobin is 9.5, does the organ function decreases more so in one of these arms other than the other or not? So the study results were that there was no statistical difference in progressive organ dysfunction in either arms. However, the restrictive arm had 44% less transfusion. And because transfusion by its own has its risk and side effects, this was seen as a reason to support that hemoglobin threshold of 7 is safe and effective in pediatric ICU patients and prevents excess transfusion. The next study I'm gonna talk about is it's something which is more recent. That one was in 2007. This is 2018. So going further step, and this is a much newer. So it was a group of, done by a group of pediatric critical care physicians, transfusion medicine physicians, hematologists, and other experts who came together to assess the overall body of literature around red cell transfusion triggers in children with critical care. So again, looking into the PICU patients. And so they published a series of articles looking into different subpopulation in children in the ICU for when you should or should not give transfusion. This was not a randomized controlled trial, but was a guideline development. So this actually diagram summarizes their study. So let's go through it. So the black box on the top left, you start where we start with a child with critically illness. So right away you see a hemorrhagic arm. So throughout this, so they are talking about this also. However, I'm not talking about the patients who are having life-threatening bleeding. My focus is about patients that are using laboratory values as a reason to transfuse. So moving down to patients who do not have hemorrhagic shock, so these ones which are not having hemorrhagic shock, it is subdivided in the 3 groups of patients based on the hemoglobin. So patients where their hemoglobin was less than 5, the author suggested you should transfuse. Transfuse red cells. 5 to 7, you should consider red cell transfusions based on clinical judgment, and then when the hemoglobin is greater than 7, this is about what was found in the also TRIP ICU study. So they suggested that they have actually subdivided these patients into different patient categories. And they suggest, there are a few situations where the author suggested that maybe a higher transfusion threshold will be warranted, and often has to do with oxygen carrying capacity. So most, you can also see that there are quite a few boxes, for example, here, where they are using clinical judgment because there are not enough evidence. And then at the bottom arm, there is you can see here, for example, the cardiac disease. And really because the heart is pumping the oxygen around the body by virtue of the blood, and children can be affected by congenital heart disease, which they have mentioned here, and often going through corrective surgery at very young age. This is the group of focus in pediatric intensive care. So you can see, here that here they put different patient category and when they should be given transfusion or not. So this is a very nice study because it is providing a nice way guidelines on when red cell transfusion should be indicated. But one thing I want to emphasize that all these recommendations, not all of them have randomized controlled trials behind them telling us the right answer. So the authors also in these guidelines, they call for additional research in this population. Now I will talk about about the babies. So in the NICU, who are usually preterm and low birth weight. So I want to tell you in this about a couple of important studies in this matter. So the first two important studies which were done in the neonatal red cell transfusion trigger, this was in 2005 and 2006. So the Iowa study and PINT study. These are historical, and there are some new studies, which I'm going to also touch after these two. So these two, the PINT study and the Iowa studies, were prospective randomized trials. They were looking at the liberal versus restrictive threshold for red cell transfusion in the NICU, who are usually preterm or low birth weight. So the Iowa study birth weight was the population birth weight was 500 to 1300 grams. And the PINT study was looking into a population with a birth weight of 1000 grams. So overall, the PINT study kids were lower weight. And the neonatologists in this study, they transfuse using day of life and oxygen requirement and laboratory values together to decide if transfusion is indicated. They use physiological markers and not only the laboratory evidence. So the Iowa study was actually comparing, so in this table, you can see the Iowa study was comparing a hematocrit where the liberal arm was getting transfusion with a trigger of 38% hematocrit, and the restricting arm was getting transfusion with a hematocrit of 28%, which is a pretty wide difference. The PINT study, on the other side, was getting a trigger of 29.9 hematocrit in the liberal arm versus a restrictive arm hematocrit of 25.3. So a much close trigger. And in clinical trial, it's kind of harder to see a difference clinically when your two arms are somewhat similar. So when you're looking into the neonatal transfusion and outcomes, we don't only want to look at the multi-organ dysfunction score, but we look into more common side effects in the neonates, which is death and severe morbidity. So in the Iowa study, the restrictive arm had more patients who met that endpoint, which was grade 4 intraventricular hemorrhage or periventricular lipomalacia or apneic events. In the PINT study, the death or severe morbidity was not significantly different between the two groups. So you can see the number of donors also and frequency of transfusions, which aligns with their transfusions if they were a liberal or restrictive arm. So what does that mean? The issue with these two studies that they have, they're not pointing in the same direction. So it still left us with the need to know what is best for this group. Another piece actually of transfusing neonatal patient is what is their long-term neurodevelopmental outcome, because these are small babies and there's a lot which can impact them, and they can have long-term outcomes in terms of developmental delay or other sort of negative neurological outcomes. So neither studies at that time when they were published, they included long-term outcome. However, in both studies, the authors did post hoc analysis of as many patients as they could get and looked into the long-term outcomes. So in the PINT study, they looked at the difference at 18 to 12 months of age, the difference between two arms in terms of death, cerebral palsy, cognitive delay, visual or hearing impairment, and they found no difference in that combined outcome. They also did further cognitive function testing on children and found that liberal threshold has better cognitive function. However, the study was not powered to detect this, and we cannot be sure if this actually means anything or not. In Iowa study, they also tried to identify long-term neurodevelopmental outcome difference, and they looked into brain structure in 55 of the transfused infants. And they found that intracranial volumes were substantially smaller in the group who received the liberal strategy compared with controls. So again, conflicting the PINT study findings. So that was about these. So there are some new studies. The top trial, it's the transfusion of prematures. This study actually looked into the, it incorporated about 1,824 infants whose birth weight was less than 1,000. They were all premature at the gestational age of 22 to 29, and they were requiring respiratory support. This population was randomized to restrictive versus liberal, with the triggered varied by the postnatal age. And the primary outcome which they were having was the death or significant neurodevelopmental impairment up to 26 months. And their preliminary results showed that there was no difference between the two arms. Now also I'm gonna talk about this, another well-powered randomized control study, most recently published in JAMA last year, the ITNO study, which studied the effect of liberal versus restrictive transfusion thresholds on outcomes in extremely low birth weight infants. They randomized over 1,000 NICU baby, low birth weight, who were premature, to restrictive and liberal transfusion, and they have the same death and neurodevelopmental outcomes. So there was no difference between actually the two arms of this study. So the author concluded that among infants with birth weights of less than 1,000, a strategy of liberal blood transfusion compared with restrictive transfusion did not reduce the likelihood of death or disability at 24 months of corrected age. So in summary, of these red cell transfusion studies that I have shown, there is some good data about pediatric red cell transfusion, and it is helping to guide the practice for the clinicians in terms of the transfusion thresholds. And it also continues to show that the benefit of liberal transfusion is not established. So there's the studies, most of them are not showing a benefit of liberal transfusion. So what about now platelet transfusion triggers? Now let's shift gears and talk about the platelet transfusion, where it is similar type of question. So do you give platelet in liberal fashion, meaning when the platelet count is higher, or do you wait to give the platelet until the platelet count is gone quite low, which is the restrictive approach? So the first randomized control trial, which involved pediatric population, is the Play-Doh trial, very famous one. In this trial that included both adult and children, they were randomized to receive 3 different levels of platelet transfusion doses. So when the platelet count dropped to 10,000, they would get a platelet dose of either 4.4, 2.2, or 1.1. And the author wanted to know if getting a different platelet dose impacted the patient bleeding. And so every day the patients were assessed for bleeding, and they were graded according to the WHO bleeding score. So grade 1, where there was no bleeding, grade 2, noticeable like a small epistaxis or gum bleed, grade 3, pretty significant bleeding requiring transfusion, and grade 4, life-threatening bleed. And one of the most important things they found, that regardless of what dose of platelets you received, the platelet dose did not correlate with the worst bleeding. Meaning if you were getting the lowest dose, you did not have more bleeding than if you were getting the highest dose. So what about, because this study included both children and adults, so they also did like an analysis for the children. They looked into the children specifically, and also according to the age, and they found that younger patients, particularly age 0 to 5 years, and all the children, they have higher bleeding rate than the adults. Not because of the platelet dose they were getting, but it seemed that children had more bleeding. So why is this? The author did not know for certainty. However, they talked about that the younger age children is the age frame where they typically gets the neuroblastoma, and these kind of malignancies are treated with tandem transplant. So it may be therapy related, other than children having other reasons to bleed more than others. But either way, this is an important finding because it signifies when we should transfuse these children and how effective these transfusions are going to be. So that was the platelet study. The other study I'll talk about is the platelet transfusion in units, is the Planet-2 study. It was done in 3 countries looking into liberal versus restrictive platelet transfusion in units. Like the other neonatal studies I described earlier, there were also babies with low birth weight and premature, and they were randomized to receive platelets, transfusion at a trigger of either 50,000 platelets or 25,000. And the author found that the composite outcome or death or bleeding happened more in babies who were receiving actually the liberal platelet transfusion approach. Author also did subgroup analysis in this study to try to understand, is it real finding or there was any selection bias? And what they found is that there was higher rate of mortality and major bleeding if they used 50,000 trigger as a platelet transfusion trigger for transfusion. And when they reduced the trigger to 25,000, this may actually prevent death and major bleeding in the neonates. So they also did the multivariate logistic regression to predict baseline risk of bleeding, and then again looked into these triggers to see if a patient has certain reasons to bleed more. Did the study finding would change? And the answer was no. No matter your pre-existing risk of bleeding, the 25,000 trigger was associated with absolute risk reduction in all risk groups. And so author recommended adopting this trigger in transfusing platelets to neonates. So by this, I come to the conclusion of my presentation. This was a quick look into some evidence-based medicine that guide the transfusion practice in pediatric patients and neonatal patients, focusing both on red cells and platelets. So all this evidence should help us develop the best patient blood management in order to do the evidence-based medicine, which is for these patients is the best. And by this, I will thank you very much for your time and attention today. And I hope that this was a good talk, and I wish you a very pleasant day. Thank you.
Thank you to Dr. Shadia for the nice presentation. I think we will leave the questions to the end. Now we will have Dr. Halima Al-Belushi. Is she here? Hello. Hello.
I would request Dr. Halima to unmute herself.
Okay.
Can you hear me?
Yes. So now we will have Dr. Halima Al-Belushi to talk about autoimmune hemolytic anemia in COVID-19 patients. Dr. Halima Al-Belushi is a senior laboratory specialist. She's also a deputy CMLSO at Royal Hospital in Hematology Department. She's also ISBT Immunohematology working party member. She's very active at immunohematology, and she participates in many projects. So please welcome Halima, Dr. Halima Al-Belushi, to the floor to present about autoimmune hemolytic anemia.
Hi, I'm supposed to share my screen with you.
Yes.
How do I do that? Okay. Okay, how to...
Halima, are you able to share your screen?
I'm trying to set. I can't find the share screen. Can you see my screen right now?
Yes.
Hi, everybody. Can you hear me?
You are very clear.
Hi, everybody. My name is Halim Al-Balushi. I would be talking today about our experience with COVID-19 patients. We are the tertiary hospital and major ICU center, like the COVID-19 patients who are very critical. They used to come to our ICU or admitted in the ICU. I will be briefly talking about this. This is just a very basic experience, our very basic experience about it. This study is not completed yet. It's very in the initial level still. So, but however, it's interesting what we have found. Of course, everybody knows about the COVID-19 pandemic, and it is caused by the coronavirus SARS-CoV-2. Severe COVID-19 is marked by virus-induced lung damage, elevated levels of cytokines, immune cell filtration in the lung, and multi-system involvement. Dysregulated immune response and increased pro-inflammatory cytokines induced by the COVID-19 virus contribute to the pathogenesis and organ damage. Okay, next. Okay. So what we did, in our experience, in our hospital, we found that in that period, in the beginning of the pandemic, we got 33 patients which presented with DAT positive, and they were severely anemic, and they were all admitted in the ICU. The age range was not specific, it was wide, from 19 years to 84, males and females equally. So, and 15 of these, like 50% of them, they died. Hemoglobin, this is the mean hemoglobin. So they come with high hemoglobin. Then within the admission, they go to very low hemoglobin, and we support them with blood products. And when you stop supporting them in days, the hemoglobin will drop. LDH level was high. However, with the time, it was reducing because maybe of the transfusion and everything. But however, it's high. It was in the higher level. So what we did is when the hemoglobin is low in our lab, we do the antibody screening. So we try to avoid any alloantibodies maybe causing this or anything. So we do the DAT, direct Coombs test or direct Coombs test, and we found that 31 patients, they're all 33 of them, they were patients who were positive, and 31 of them were having only IgG. One of them had IgG, IgM, and C3C, and C3D. One patient had IgG, C3D only. And just to make sure, most of them, the one had IgG, IgM, and C3C, C3D, he died. And the one who had IgG, C3D also died. And the patients, majority of the patients who had only IgG died also. So it was not specific, death was not specific to one of the antigens or something, autoantibodies or something. No, it was spread, the patients were critical. So that's why we couldn't make out what was the reason of the death exactly. But this is my personal research. I thought maybe this is a sign of autoimmune hemolytic anemia. The COVID-19 is causing autoimmune hemolytic anemia. However, at this stage, we cannot say that it is definitely that the COVID-19 causes autoimmune anemia, but as the literature says, maybe the mechanisms that are responsible for generating these autoantibodies in COVID-19, maybe it's because of the cross-reactivity between viral and proteins, viral proteins and autoantigens, molecular mimicry, induction of apoptosis of virus infected cells. Autoantibodies are, maybe they are anti-idiopathic antibodies to antiviral antibodies. IgM plays, IgM produced by the immune system as protective during the infection as a protective measure. Induces complement activation, enhances antigen presentation, thereby enhances subsequent adaptive immune response. Also, the presence of IgM, surface IgMs, led to the enhanced protection against production of anti-inflammatory cytokines and interleukin 10 by T and B cells, and apoptosis will occur. Hyperinflammatory of COVID-19 enhances the deposition of complements and binding to the IgG autoantibodies, which promotes clearance and damage of the RBCs by macrophages. So, yeah, my talk is very brief because it still needs a lot of work to be done in this area. But what we have seen that there is an autoantibodies, there are destruction of RBCs, there are production of complements, activation of complements, and but are we sure that the immune hemolytic anemia is occurred because of COVID, or is it because of something else? We don't know. Anyway, I hope it was a simple and very small talk. It's not boring. Any question? Hello.
Thank you, Dr. Halima, for the brief presentation about your study. Is there any questions? I'm not sure if the audience are there.
Yeah, I'm not sure either. Maybe they left.
No, some.
Okay.
Yeah,
Is there any questions for Dr. Shadhia, please?
it's okay, we can proceed.
I think I don't think there is.
While
Yes.
we are waiting for other people to ask questions, I would request everybody to please switch on your cameras for just a second. We need to have a group photograph. I would request everybody to please switch on your cameras. We will have a group photograph which will be shared amongst AATM members. Thank you, everybody. I would request our president, Dr. Navjyoti Chaudhary, sir, to please switch on the camera. Great. So we'll be going in for the first screen now. It won't hurt if everybody smiles. Thank you. So the screen 1 is done. Screen 2 is done. Screen 3 is done. Wonderful. Wonderful. Everybody's there. Thank you so much. I hand over the mic again to Dr. Zainab. Please continue, ma'am.
Can I ask one question to Dr. Halima? Zainab, if you allow, can I ask one question?
Yes, please. We have
Yeah.
time, plenty of time.
Halim, a very nice study, and I think it's good that we are collecting these patients' data. Did you find any specificity on the antibodies? The positive DAD. Was any specificity found in these patients for any antibodies?
We did elution test on them. There was no. They were negative.
Okay.
And plus we made sure that the patient has no alloantibodies. So these patients, they were not having any alloantibodies also. So it just was non-specific and negative for elution.
Okay, thank you.
Okay, thank you everyone. So I think if there is no question, we will conclude the meeting. And at the end, I would like to thank Dr. Ankit, Dr. Mushtaba, and the organizers for organizing this meeting. And we'll see you again, inshallah.
Can I add one thing?
Next, yes, please.